Thank you to the college for asking me to come on and speak today, and our experience in North West London around the AIDF process and how far we've got so far. So I'm a radiologist at Hillingdon Hospital, which is in West London, close to Heathrow. It's a small hospital, but my other hat is as co-clinical lead for the North West London Imaging Network. And we've been in network for about 5 years and don't have anything to disclose. What's the slides on?
Yeah.
So what I'll go through is the AIDF timeline, how NHSE have set up their process, and how we stepped through that as a network in North West London. So the whole announcement from NHS England was made on the 23rd of June, so this means that the NHSE tree starts the cascade process down to people in your region, that there's going to be some money. So that feels like a long time ago now, but the 23rd of June there's going to be £21.3 million, and they would like these tools deployed before we get into winter pressures. So this is very management speak, very NHS England speak, not something that we necessarily have to work with too much as a ground floor radiologist. The good news is that the fund is managed between NHSE Digital Diagnostics Programme and the NHS AI Lab, and they've been working together to develop this programme. So two major objectives. It's to increase or improve diagnostic capability. It was really promoted as looking at chest X-ray AI, but also a longer-term goal in terms of to improve diagnostic services and waiting times for patients in the long term, reducing the administrative burden on clinical staff. I'll leave you to ponder the long-term goal. So, the background. Why radiology diagnostics and AI? Because broadly speaking, we're the most mature area for healthcare AI products. You'll all have been to conferences and seen large numbers of products promoted. You probably have played with some of them yourself. NHSE and the AI Lab felt that radiology diagnostics was most ready to have a go at a large deployment. I think just in terms of managing the process, they wanted the bids to come through radiology networks rather than come from local trusts. There are 22 networks nationally, one bid per network. And it was chest X-ray, but they were open to considering other areas. And in reality, there have been 10 successful bids, 7 are for chest X-ray AI and 3 are for CT nodule AI. But the other areas, you had to fulfil some specific criteria that are listed there. It was funding for a product. It was absolutely not funding for a platform. So interesting, problematic. National funding process, but a local procurement, not a national procurement. That was a point of discussion right at the beginning. And they want this in clinical practice by the end of March. It's the 11th of March today. So we'll see how we get on. So the timeline. So it's June. People are starting to think about summer holidays. Oh, thank God for that. We've got a few weeks off. We can relax. We might be wrangling children, or we might be just relaxing, doing hobbies, or going somewhere hot and sunny. But we're starting to think about the holiday period. So NHSE have a network awareness session on the 3rd of August. Then they provide us with a costing tool to help us to build up a business case. And then we're straight into, we can start developing our bids. The bullet points in green are what the networks are doing at the trust level. And then there's also a regional moderation. So we have to work things up. We have to go through our region. For us, that's NHS London. So we've got a month when everyone's on holiday to work all of this up. No worries. Then that all goes into NHSE. There's a moderation programme, and basically this turned into an extended dialogue to and fro about what we put in and the money. And all of this was to neatly come to an end by the 16th of October so that we could then move into procurement. Is, as I said, a local procurement. This is all going to happen at network level, and we're going to step through that nicely, and our tools are going to be deployed into clinical practice on the 31st of December. So I've got a couple of slides here around NICE. Alongside this, you see this all started at the beginning of August, and NICE published their health technology evaluation on the 28th of September that said, well, actually, that's all well and good, but we're not really ready. I think the key point on this slide really is access to technology should be through company research on non-core NHS funding. So I think this is the space we're in, it's non-core NHS funding. Nevertheless, this was chest x-ray, GP patients, lung cancer, the use case they were suggesting we might want to look at, and NICE said we're not ready. More research is needed, a lot more information is required, but this is not a research project, this is clinical deployment. So, a little bit more about us as a network. We're quite a mature network. We've got a good network structure and governance. We are comprised of 4 acute trusts with 2 associate trusts. The trusts are Imperial College, London North West, University Hospitals Trust, Chelsea Westminster and Hillingdon. Our patient population is 2.4 million. We do have a network digital programme. Where there is an innovation lead at Chelsea Westminster who's working with Palantir on developing some interesting tools and had a wide NHS impact with that. We've obviously got a large research base at Imperial that Andrea and colleagues run. So a huge amount of local knowledge in terms of AI research. We have got as an AI strategy, let's have some clinical tools and let's work on operational AI, but we haven't got any further than that. We've got 2 PACS providers, the 4 trusts, 1 risk provider, but they're all separate instances. We don't have an AI platform and we don't have any deployed clinical products. So I think you've heard from previous speakers around who might need to be involved in this. And this is our map of who our stakeholders are, and that we use to inform the group that we formed for this project. So who's in our team? We've got managers, we've got digital leads within the network, we've got trust digital leads, we've got the innovation lead from Chelsea and Westminster Hospital, we've got a range of other colleagues, including finance and procurement colleagues, because we've got to get a lot done in a very short space of time. And basically we had weekly meetings. We're still having weekly meetings. So the big development, lots of tools, lots of potential uses for those tools. You've heard already every tool and every use case, there's a huge amount of data to be processed. Are we sure this is going to work, even if this is a deployment as a clinical tool, regardless of whether you take it through a research tool and research background. When we looked at this, we did talk about, are there other use cases, are there other tools, and we felt if we were going to progress that we should keep it simple and go with what was the suggestion from NHSE, and we felt in principle that there was an unmet need in North West London that this would have a real world impact potentially. So we went with identifying normals and looking at chest x-rays that would identify features suggestive of lung cancer. And what would the benefits be? That list there, it is longer than that, but they were the key points that we felt that we would need to pull out, and these are reflected in the data that we've been requested to collect. What are the risks? We don't have any North West London ground truth, and we do feel that that's really important. And one thing that we've added into our project is that we are going to run a cohort of patients through the research PACS to see what the North West London ground truth is. We also had a lot of discussion about where does this align with other projects? There are only so many people, there's only so much bandwidth. Could we actually even do this before we even get into making a bid? How are there so many other big projects, PACS procurements, PACS refresh, other digital projects? Could we actually do this? And the answer was probably, so we decided to go ahead. Procurement, lots of people on the market. What could this procurement look like? A terrifying prospect. And then once we've gone through all of that, what's it actually like in terms of engagement? Will people want to use it, etc.? So then we had to develop the business case. We played with a lot of options. 320,000 chest x-rays in North West London performed every year. We decided to go with all chest x-rays, not just GP chest x-rays, but GP chest x-rays are quite small numbers. We looked at a lot of literature. 10% improved reporting efficiency we thought was probably reasonable. We also put in our business case for 30% of normal chest x-rays would be auto-reported, so we would stop doing them, save those man hours and use them for something else. Now, those in the audience who think about that might think, well, is that actually deliverable? In reality, it probably isn't at the moment. But we would expect to reduce WLI spend on chest x-ray reporting. Quite a bit of variation in the network. We've got different pathways, different volumes, variations in performance. Some people are on point, some people aren't. The pricing tool was helpful to some extent. Broad brush. Some of the AI providers provide you with a cost per item. Others have thresholds in terms of volumes and thresholds. So very hard to work out what it might actually cost. We put together a 5-year a business plan that was going to be a spend of £1.5 million. So these are not cheap things. They have to be value for money. They have to pay for themselves in clinical practice. The financial situation in North West London, not unique to North West London, but they said basically if this business case doesn't wash its face, it's a flat no. So we had to come up with something that looked like it was going to make sense, and our initial bid was for 745,000 capital submission. That's what we agreed with NHS England, that's what we agreed in North West London. In the end, we flipped that to revenue and we truncated the business case at 2 years. But we didn't get that agreed until the 8th of November. We had to pivot because we couldn't rely on not reporting 30% of normal chest x-rays in the business case. So how much money did we actually get agreed with NHS England in the end? 960k, because effectively the starting point was our outline business case. Once we really knew, once we got our preferred provider, what's it really going to cost to do it? It was actually rather more. We had to include VAT in that. Capital depreciation, speak to your accountant. We put a small contingency in there. As I say, we made it very clear this was a 2-year contract, because if it isn't value for money, if it doesn't work, we will not continue into clinical practice because it will need to be paid for locally. So that was all finally agreed on the 22nd of December with NHS England. So you can see we were into procurement and beyond, and quite committed in terms of time and effort locally before we were certain that we actually had the right amount of money to run the project. Conditional on baseline data. Data. So we had to collect data locally to inform the outline business case, but then when it came down to it, we had to form a huge amount of data, open to interpretation. The data was discussed with networks and wider stakeholders in terms of, well, what would the data what would we need to collect to give us assurance that actually we've got good information about how it actually works in clinical practice, the false negatives, the false positives, all the stuff that you've heard other speakers speaking about earlier today. Interpretation of how you create that data, it varied between trusts. In reality, every trust had to provide their own data. We had to report it for the network altogether. Multiple sources of data, not easy to find. It's fair to say that there were some interesting comments from our PACs and risk managers. Where do you think we're going to find the answer to that question? And when you want it by Friday. Oh, okay. That would be a no. But as you can see, you don't get the money if you don't give the data. So everything's tied together. And it doesn't cover the whole of the data collection that might would like. And you know, we're all aware that there is potentially a gap there. Commitment to money and doing this is commitment to evaluation. So we then step into procurement, Crown Commercial Services. This is national sort of public service procurement, dynamic purchasing system. Once you filter that down into health, into digital products and then AI, you've got 69 potential bidders. Okay, that sounds like a complete nightmare for a procurement process. We can't possibly evaluate 69 potential bidders. There are 30 products out there internationally. Are they on the framework? We didn't know at this stage. We have no idea. So what we did to try to calm our own nerves and manage some of the risk was to put out a request for information. And we focused on some of the, will it integrate with our products, our packs and risks? Will it be able to work with an HL7 risk reporting work list? And has it got the right regulation? And as you've heard, the regulation is a bit of a minefield. We also wanted to get a good idea of what was really going on with the companies before we got into a formal procurement. Because once you're into a formal procurement, it's essential you treat everybody exactly the same. We did do that with the pre-market engagement, but it was very short notice. They were all super keen, but we did have to gather a wide range of people. We had 10 people that came into the room. Some of them were platforms, some of them were individual app providers. Just to get a feel for them. The other good thing for us was that our RSNA came at a good time for some people in our team to actually go and play with the products. So formal procurement, there was a document from NHSE to help us with that, but we recognised that it was very generic. How are we going to differentiate between all of those people? Ideally, we wanted to have an app with a platform, but that isn't part of the finance. But would it be possible, the platforms were really keen. So would it be possible to have a platform with an app provider some way, somehow through this process? And the way that we phrased our requirements was to give very specific advice about how a platform provider could write their bid document with a chosen app provider so that we could measure apples and apples instead of apples and oranges. And there was only one platform provider that actually really had a good stab at that. In the end, they didn't come top of the pile, so we didn't get our kind of, holy grail, if you like. So in terms of the moderation process with NHS England, once we'd finalised our procurement, got our preferred provider, we then had to go back to NHSE. Even though this was a local process, they wanted to moderate our decisions because they wanted to have a range of providers. They wanted to create competition. In terms of where we landed, the final confirmation of the money was the middle of January, and then the notification at the end of our procurement period was the 12th of February. The letters went out to the suppliers with the preferred supplier, and then there was a short standstill period, and we're now into the phase where we are starting contracting. So what I hope you can see is that it was an incredibly tight timeline. What we've done in a very short period of time is climb several mountains. They felt unscalable at times, it'd be fair to say. It soaked up an absolutely momentous amount of time. And we had multiple go, no-go conversations at different points through this process. Are we really sure we're doing the right thing? Have we got the right people? Have we got the right resources, not just money and data, but can we keep moving forward? Because once you're into it, actually, there's another whole ton of work to do, evaluating your data, getting it into clinical practice. The data I talked about, very complicated, really important, because is it really good enough? It's all going to be founded on the data. There are lots of other things in here that I've got listed, but I think they're the two key things at this stage for us. A lot of other things on the other side, though, in terms of support. There were weekly meetings run by NHSE, twice weekly meetings at one point, actually. One that was run specifically with technical colleagues. There's an NHS Futures site. It's split into two domains. One is for the providers of the AI, the other is for NHS staff. They're completely separate. They have worked with the suppliers to get them onto the framework. They provided a lot of template documents for us, As I say, the pricing tool, they provided IG templates, and they're obviously working hand in hand with NIHR. Where we are at the moment is where I say we're stepping into contracting and the minefield that is IG. We've had varying experience. We've had some projects that have taken a few weeks, some that have taken many months. So I've got the CCIO on speed dial, and I'm hoping that means that we can step through our IG minefield without too much trouble, but we really have no idea how long it's going to take. I don't think we're expecting to go into clinical practice probably until the summer, so a year after we started. And that's with an accelerated process. Okay.